Dr. Sassine, what are your thoughts on the efficacy comparison between autologous and allogeneic therapies?
But you can think of a couple if this then that situations where, if you're asking the question, will allogeneic CAR T cells, for example, completely dethrone autologous CAR T cells for the same indication? I think for that you would have to show, like Dr. Awan said, you have to show that it's at least as good, convincingly, both in safety and efficacy, and that it has all of the other advantages which you would expect from an allogeneic product, like the alleviation of the bottleneck potentially in the leukapheresis step, the nursing step there, you can accelerate the time to treatment, which of course you would. You can avoid the manufacturing failures that could happen with an autologous CAR product. Although I should mention that one way out of that is just, if you like auto CARs, to just do your auto CAR and then wait for it to become, for those few patients that have manufacturing failures, you can just switch to the allo product. So it's not a reason to just switch across the board, but if you could achieve comparable safety and efficacy with all of the other advantages, and if the cost is at least reasonable compared to what we're paying for the other ones, then I think that's one way to become king of the hill. But more realistically, I think you could also imagine a situation where, let's say you do take a hit on the durability side of the response. So maybe your response rates are a little bit lower, maybe the duration is a little bit lower, and maybe the safety isn't quite as good or isn't obviously better. Well, now maybe you would just choose other patients to give that product to versus your auto CAR product. And so I mentioned one example, which is in the event of a manufacturing failure, or let's say a very rapidly progressing patient where you don't think you could get them an auto CAR product. Maybe there's some compelling reason to give it in a subset of patients, and it depends on the indication too. So, for example, let's say if you have, for most lymphoma patients, at least in my practice, we are not routinely consolidating with a transplant after CAR T. We're using it as a standalone therapy. But for leukemia, we often do an allogeneic transplant after CAR T. Not everybody does this. I don't know if it's standard practice, but we believe that there's enough data there to justify that in at least the especially high-risk patients. And in that circumstance, if you're going to consolidate with a transplant or some other therapy, even if the allo CAR data looked worse in terms of durability of response, maybe you could use it as a bridge to transplant in some patients. Obviously, that's, you don't, if you're making an allogeneic product, you don't want to have to think about that situation, but I think that is a likely reality.
Yeah, so in the way you're describing, Dr. Sassine, you see a place for both, depending on how the efficacy might result from the trials. Do you see one becoming more dominant than the other?
Yes, and that would depend on the data. So if it turns out that the allo CARs have comparable safety and efficacy, then I think most of us are just going to, if not immediately, but eventually start to transition to the allo CARs. If it turns out that auto CARs retain what appears to be, and we'll never know, I doubt there's going to be a randomized trial anytime soon, but if it appears on first glance that auto CAR has a better durability of response, at least I think for myself and many of my colleagues, we would still prefer auto CARs in many patients outside of some compelling reason to go for a product with a lower efficacy.
Is there any reason to believe that allo CARs may have lower efficacy than auto CARs?
Yes. So at least empirically, it's not clear that they're better from a response rate perspective. I've actually been pretty impressed, given the challenge, scientifically, of trying to cross this barrier. It's really, really impressive what they've been able to achieve so far. So I don't want it to sound like I'm not impressed. I very much am from a scientific perspective. From a clinical perspective, it's not clear to me that this is going to be any better, and it does seem to be a little worse in terms of the efficacy from a response rate perspective. From a durability, we only have a very limited number of patients to go off of, but at least from there, it does seem like the response duration might be a little bit worse than the auto CAR products. And then if you just think about it hypothetically, a lot of these auto CAR patients are having responses that deepen over time. And what period of time? Well, sometimes 6 to 9 months later, this response is still deepening. And it's conceivable that an allo CAR T product could stay in the body that long and could mediate a response post 4 to 6 months later. But I think it's a lot less likely. So I think on average, you're going to see some downtick in the response durability, even if the response rates are the same.
Yeah, I agree with what's been said before. I think they're very exciting. The preliminary data is also looking pretty good. If we get more information on that, then that's great. I think the GVHD risk with some of the new CAR T constructs is pretty minimal for the allo CAR T, fairly similar to allo NK, because you can, in theory, delete or add whatever molecule you want, which might be important in mediating GVHD. So I think that's also possible. So at this point, both of them look very exciting. Can I pick a winner? I don't think so. I just feel that they're both equally promising in my eye. Obviously, NK cells are also very interesting, and NK cell, the system is obviously well established in the innate immune system, and maybe we can combine both at the same time at some point. So yeah, it's interesting how this thing is evolving.